Epithelial ingrowth, though rare, is a potentially sight-threatening complication that may be seen in nearly 4% of cases after LASIK. Successful management requires a relifting the flap and complete removal of all interface epithelial cell nests. In addition, application of mitomycin C, ethyl alcohol, sutures, or glue have been described to prevent its recurrence. Preoperatively, anti-segment OCT can be used to delineate the location and extent of epithelial ingrowth and help in surgical planning. Intraoperative OCT has emerged as a useful tool to aid intraoperative decision making, and we describe its utility in the surgical management of epithelial ingrowths. We here present a spectrum of cases with management ranging from observation alone in peripheral epithelial cell nests to intraoperative OCT guided removal of epithelial ingrowths and to flap amputations. Case 1 was a 25-year-old female who presented with epithelial ingrowth encroaching the visual axis. Epithelial ingrowth was visualized as a hyperreflective area in the interface on IOCT, and the location extent were noted at the beginning of the procedure. A simple dimple down maneuver was performed to identify and highlight the circumference of LASIK flap. A LASIK flap lifter was used to cleave the flap edge inferiorly and lift a limited area of LASIK flap overlying the involved area with epithelial ingrowth. IOCT was used to confirm entry into the correct corneal plane while lifting the flap. The flap overlying the uninvolved corneal stroma was not lifted to minimize unnecessary interface disturbances. The epithelial ingrowth was scraped off from the stromal bed as well as from the overlying flap using the blunt iris spatula. And the completion of removal of epithelial cell nests was confirmed on IOCT as smooth stromal surface was visualized. 20% ethyl alcohol and mitomycin C 0.02% was applied to the stromal bed and underside of the flap to prevent recurrence. The interface was irrigated with balanced salt solution and the flap was gently repositioned. Optimal apposition of flap and the regularity of the interface was confirmed on IOCT at the end of surgery. Post-operatively, the visual axis was clear with uncorrected visual acuity of 20/25. In case number 2, a 27-year-old female who presented 2 years after a SMILE procedure with progressive paracentral epithelial ingrowth. A dimple down maneuver was performed with the reverse cytomeracil response to highlight the capside cut, which was subsequently reopened with the thin blunt instrument. The SMILE interface was locally dissected superiorly and the epithelial cell nests were completely removed under IOCT guidance. Only the area surrounding the involved interface was manipulated and the entire interface was not dissected. IOCT helped to confirm the extent of interface dissection as well as the completion of removal of epithelial cell nests. The interface was subsequently irrigated with balanced salt solution. Post-operatively, the patient was 20/20 with minimal interface scarring and no recurrence till 2 years of follow-up. Case number 3 was 26-year-old male patient who presented with diminution of vision in his right eye for last 1 year, associated with trauma with the fist. On examination, superior-temporal dislocation of LASIK flap was visualized with the fibrous, shrunken flap and multiple full-thickness fixed flap folds in the visual axis. Anti-segment OCT revealed a 288 micron thick epithelial ingrowth in the interface. Flap amputation with removal of epithelial ingrowth planned in the right eye, considering the long-standing history of flap dislocation and presence of a fixed folds in the flap. Retroillumination fundal growth under the microscope help the enhanced visualization of flap edge. A blunt tip flap manipulator was used to delineate the flap edge and cleave it from the underlying stomal bed. Flap was separated from the underlying stomal bed using the flap manipulator, and the flap edge was grasped with a forceps to gently tear it off from the superior hinge. The epithelial ingrowth was scraped off from the stomal bed with a blunt spatula, and IOCT was used to confirm the completion of removal of epithelial cell nest. Mitomycin C soap Merocel sponge was applied over the stomal bed to prevent recurrences. A bandage soft contact lens was placed over the corneal surface at the end of surgery. The patient regained post-operative uncorrected visual acuity of 20/32 with a smooth, regular stomal surface with no recurrence till 1 year post-intervention. IOCT guided management of post-LASIK and post-SMILE epithelial ingrowths enables a real-time dynamic monitoring of intraoperative surgical steps, helps identify an interface, aids in decision making regarding the completeness of ingrowth removal, which may decrease chances of residual cell death, and also helps in a final assessment of optimal flap apposition at the end of surgery. This is the first report highlighting the utility of IOCT in achieving optimal visual and anatomical outcome in cases of epithelial ingrowth in post-LASIK and post-SMILE cases. Intraop OCT definitely adds into the routine microscope evaluation during surgery and helps prevent recurrences in these challenging cases.